Like a 33-year-old Afro-Caribbean woman presents with 6-month history of intermittent grumpy abdominal pain and bloating. She also reports some mild constipation. She denies any vomiting or any urinary symptoms. Her past medical history includes appendectomy and hypertension. She currently takes amlodipine 5 mg once a day and drinks 8 units of alcohol per week. On examination, her abdomen soft and normal bowel sounds, and there is a palpable non-firm tender, non-tender, firm non-tender. So palpable, firm, non-tender abdominal mass arising from the pelvis. So her blood tests and everything is here. What is the cause of abnormal blood test results? Here in her blood test results, hemoglobin is elevated. That could suggest polycythemia. And in her history, that firm non-tender abdominal mass arising from pelvis likely could be her uterine fibroids because it's from pelvis. So fibroids are benign tumors, benign tumors. So these this so chronic blood loss could happen because of menorrhagia could happen from these fibroids and triggering this could trigger increase in red blood cell production. However, in some cases fibroids may also produce erythropoietin. That's the thing. So this erythropoietin fibroids may produce erythropoietin. So that could in turn lead to increased production of red blood cells leading to polycythemia. So her normal beta HCG level rules out pregnancy. So this non-tender firm uh, mass could be this mass could be from fibroids. And so option normal platelets, everything normal, right? Normal platelet and um, normal platelet WBC. So now see autonomous erythropoietin production due to uterine fibroid, autonomous erythropoietin production due to ovarian cyst, no excessive bone marrow cell production due to paraneoplastic syndrome, no excessive bone marrow red blood cell production due to polycythemia vera. So autonomous erythropoietin production to ovarian cyst. While ovarian cyst can sometimes cause hormonal imbalances, but these are not known to produce any erythropoietin. And next, uterine fibroids. These are documented to lead to polycythemia in rare cases due to increased erythropoietin secretion. So, and excessive bone marrow red cell production due to paraneoplastic syndrome. So, this paraneoplastic syndrome can occur due to cancers, malignancies that trigger abnormal hormone or cytokine secretion. The patient has a firm but non-tender pelvis mass, which suggests benign like benign causes, firm but non-tender. So there is no mention about the malignancy, and also this looks more uh, like benign rather than malignancy driven malignancy driven paraneoplastic process. And next, excessive bone marrow uh, red cell production. Yeah, this paraneoplastic, if there is a there would be um, elevated levels of WC platelet count, right? WC would be high. These are WC platelets. Everything is normal, so this is not cannot be um paraneoplastic syndrome. Okay. Um, Next, excessive bone marrow red cell production due to polycythemia vera. So polycythemia vera is primary bone marrow disorder. Okay, characterized by an increase in all blood cell lines. If it is a polycythemia vera, all other blood cells also could have been raised. Okay, so including elevated platelets and WBC. But this patient's platelet and WBC counts are normal. Polycythemia vera is driven by mutation in a JAK2 rather than autonomous erythropoietin secretion. So this is not the case. Next one is physiological increase in marrow red cell production due to pregnancy. So there is nothing evidence against pregnancy does not increase red blood cell production. Usually that is not the case. But they also give beta HCC level, right? It is only 5. It's below 10. Well, usually above 10 is considered as pregnancy. So the patient's beta HCG is 5, so effectively rules out pregnancy. So overall, autonomous erythropoietin production due to uterine fibroid fits the best with her symptoms. The palpable pelvic mass and elevated hemoglobin without significant platelet or WBC changes. So that's the correct answer.